Hello, and thank you for joining us on the Hoag live stream to talk about acid reflux tonight. My name is Caitlin Houghton, and I am an assistant professor of surgery at USC. I'm also faculty at the Hoag Digestive Disease Center. I'm one of the surgeons that focuses on hiatal hernias and acid reflux, and I'm excited to share a perspective on acid reflux and share with you tonight everything you need to know about acid reflux from a surgical perspective. So I'm a surgeon, as this is, multiple specialties treat acid reflux. There's gastroenterologists, primary care physicians, and surgeons. And we all have slightly different approaches to treating acid reflux. And I'm going to, hopefully, by the end of this talk, you'll understand a little bit of why a surgeon comes into play and who needs a surgical intervention for acid reflux. So there's several objectives tonight. One is to kind of discuss myths and misinformation surrounding acid reflux. And one of the main things I want you to get out of that tonight is that as common as acid reflux is, it should be managed with a provider hand in hand. You should have a provider helping you manage your acid reflux, kind of let you know a little bit of how acid reflux comes about, and hopefully you'll understand how the anatomy contributes to acid reflux and why that's important. The progression and complications of acid reflux. And so by the end of the talk, you'll understand acid reflux, how that can progress to Barrett's esophagus, and how that has a correlation to esophageal cancer. And then the treatment options. And when PPI or antacid medical therapy isn't enough, and when surgical treatment becomes an option. So GERD, as we know, is really very common. 44% of people have heartburn at least once a month. 10% of the US population experience heartburn symptoms daily. And GERD is a serious medical condition that produces a wide variety of symptoms and complications, and often is not taken that seriously because it's so common. So what is gastroesophageal reflux disease? Basically, it's passage of gastric contents into the esophagus, and it's a normal physiologic process. So there's a normal amount of acid that passes into the esophagus in a normal patient. But when that becomes pathologic or troublesome, it's when it's causing symptoms of acid reflux, but not only that, causing injury as well to the lower esophagus. This can be debilitating. Patients often are complaining about either heartburn, have bile, throwing up at night, regurgitating food, and then if you take a look on the inside, you can often have injury to the distal esophagus as well. In order to kind of understand acid reflux, we need to know a little bit of anatomy. The esophagus passes through the diaphragm into the stomach. And right at that barrier between where the esophagus passes from the chest to the abdomen, there's a valve called the lower esophageal sphincter. And both that muscular sphincter, called the lower esophageal sphincter, and the diaphragm contribute to the barrier of acid reflux, and that barrier of having gastric contents wash back up into the esophagus. So acid reflux is really an issue with that barrier function. This video kind of shows dynamically what we're talking about. This is the esophagus. There's this valve where you can see the diaphragm and the lower esophageal sphincter contributing to this barrier, preventing acid washing up into the esophagus. When there's too much acid coming up here into the esophagus and causing injury, then there's an issue. As you see, when that food bolus goes through, it should snap back shut, and if it doesn't, that's when you have a problem. So a normal sphincter valve creates a barrier against reflux. And when that barrier is not normal or weak or defective sphincter, allows that gastric juices to come up and injure the lower esophagus. So GERD is really an anatomical issue with the valve that really should be protecting you from pathologic reflux. So it's a poor valve. there's acidic contents in the stomach. There's also other enzymes and bile that are in there that can cause injury as well. The stomach lining is equipped to handle that kind of exposure, but the esophagus isn't. So that's when you run into problems. Why is the valve weak? We get asked that a lot. Why do I have a weak valve? And it's really unknown. We don't know exactly what leads to that dysfunction of the valve, but it can weaken over time, so age. We think genetics has something to do with it, or family history. Sometimes there's a strong association with Heidel hernias. So often you hear a Heidel hernia, and that can basically puts the valve in the chest where it shouldn't be, and that will weaken it as well. So we're going to talk a little bit about Heidel hernias because they're so often linked. A Heidel hernia is basically a portion of the stomach that is protruding through a hole in the diaphragm that's normally there and should be just big enough for the esophagus to pass through, but some of the stomach herniates or comes up into the chest. And you can see in the diaphragm, there's a little ball of stomach that's above the diaphragm where it shouldn't be. And that contributes to acid reflux because if it's up there, now the diaphragm is not helping with the barrier because it's in the wrong location. It's pressing on the stomach instead of the esophagus. And the valve doesn't work in the chest as well because of the pressure gradient in the chest. So the treatment for Heidel hernia and acid reflux is often the same when you're talking about a surgical intervention. So when we get are sent a patient that has acid reflux and is considering a surgical treatment, there's studies that we need to do to confirm the diagnosis of acid reflux, quantify how bad is your acid reflux, see if you have any injury to the esophagus mucosa. And so there's several tests that we will usually have a patient undergo before we decide surgery is the right option. Those include an EGD or a scope, looking on the inside and seeing the injury of the esophagus. That can also tell us if you have a Heidel hernia. At the same time, we'll do a pH probe or a Bravo capsule, and that's going to tell us, it's a little capsule that's placed in the esophagus, and it measures how much acid is coming up into the esophagus and gives you a score so we can see how bad is your acid reflux. Often we'll do a video swallow or an esophagram. That's like an x-ray study where we watch dye goes down as you swallow to see if you're refluxing. Does it go down normally? Do you have a big Hiatal hernia, and what does that look like? And then esophageal manometry is a study that shows us the pressure of the esophagus. The esophagus squeezes food down into the stomach, and that can be weak if you have a long-standing injury from acid reflux. So we want to know if you have good esophageal motility or squeeze so that when we reconstruct the valve, we know that we're not making it too tight so you can't swallow. Some of the symptoms of acid reflux, not always heartburn, but heartburn is the major one that everyone thinks of, that pain in the chest after eating, maybe a bad taste in the mouth, but it's kind of a burning type pain. But there's a lot of other symptoms that can also be contributed to acid reflux. Regurgitation, epigastric pain or pain kind of like in the abdomen, a bitter bile taste in the mouth, chest pain. It's interesting, a lot of patients will go into the hospital or go to the ER with chest pain thinking that they have a heart attack. And often that ends up, not often, but after a cardiac workup, if it's not the heart, it can be attributed to acid reflux, and that's not uncommon. Difficulty swallowing or choking on food, nausea and vomiting can sometimes be a symptom, sore throat. And then there's a whole other host of symptoms. Asthma, it can reflux all the way up into your lungs and cause issues. It can cause a hoarse throat, cough. So as you can see, this list is going to go on. There are so many symptoms that can lead to acid reflux. It's not just heartburn. And so we really do, these can overlap with other conditions. We need to understand what we're dealing with, and that's why the workup is so important. So is this a serious problem? There's this burn that seems serious. How do we put that out? It is a serious problem because acid reflux can comes along with so many other complications. Those complications can be esophagitis, or almost like ulcers of the esophagus, erosions. That's inflammation, little ulcers that are a chemical burn, and it can look like this. We can also find esophagitis that looks even worse. This is really bad, like the worst esophagitis you can have, but that can also then lead to nodular areas, which are concerning for esophageal cancer. Strictures, another, if there's repeated injury, as your body tries to heal that injury, you can have scarring, and that leads to strictures, which often the symptom is usually difficulty swallowing or food feeling like it gets stuck. So, and then poor motility. So we kind of already touched on that. Chronic injury to the esophagus can lead to decrease in the pressure of the squeeze of the esophagus. And that is called, we call that dysphagia, or problems with swallowing. So there are some other problems, pulmonary problems like acid reflux, cough, frequent bronchitis. Those things can be from acid reflux. They take a little bit more teasing out to figure out whether that really is acid reflux or not. And then ENT problems like voice changes and hoarseness can also be acid reflux after everything else is ruled out. So the next thing I want to talk about is Barrett's esophagus. Acid reflux can cause injury, like we said, esophagitis, strictures, symptoms. But then it can progress to the next step, which is Barrett's esophagus. And Barrett's then, if it gets out of control and gets worse, is the precursor to esophageal cancer. So Barrett's is, we have to pay attention to that, and we want to be able to understand what Barrett's is. It's a change in the lining of the esophagus. Basically, the esophagus is trying to mimic the stomach so that it can handle the injury. So it's kind of replacing its normal lining to mimic gastric lining. This is a problem, though, because as it does that, it doesn't always do that perfectly. So you can get some disorganization of the cells, and once that happens, that disorganization then can cause more disorganization, and that's what leads to cancer. 10 to 15% of people with acid reflux will get Barrett's, and it's more common in males than females. Like I said, it is a precancerous lesion, and it's an abnormal lining of the esophagus. You can see in this picture everywhere that it's like really pink instead of that whitish color is Barrett's esophagus that's creeping up the esophagus. It's usually related to bile and not just acid. So when there's a weak valve, you have all gastric contents are passing through that valve. Acidic contents, but also bile. And so the bile, we think, has something to do with the change in the mucosa to Barrett's esophagus. That's an issue because antacid medication only treats acidic reflux, but if you're refluxing bile and it's causing injury, then you're not, by taking antacid medications alone, you're not really treating the entire problem. And as I mentioned or alluded to before, there are 3 types of Barrett's, or there's a progression of Barrett's. So there's the first type where it's just a change in the cell type. It's trying to mimic the stomach mucosa. That's called metaplasia. Then there's low-grade dysplasia. That's the disorganization. Now it's changing, but the cells aren't quite doing it properly. And so you have some disorganization of the cells, and that can be low-grade or high-grade dysplasia. Once you get to dysplasia, it's concerning because that's the next step is esophageal cancer. So we take that very seriously. But we also know that Barrett's goes through all of these phases before getting to cancer. So if you have Barrett's and it's no dysplasia, we have time to treat it and intervene. So if you have no dysplasia, the lowest type of Barrett's you can have, you have about a 40 times risk of the normal population of developing adenocarcinoma, which is esophageal cancer. And that risk increases over time. So it's only about a 1% risk per year of developing cancer. Low-grade dysplasia, it's about a 2% risk per year. In high-grade dysplasia, you have 40 to 50% already have invasive cancer. Our detection modalities aren't great. So once we detect high-grade dysplasia, often there's actually already cancer cells in that area. We just haven't found them yet. So Barrett's esophagus is one of those conditions that often is downplayed, but really we need to intervene and take it seriously because it is the precursor to esophageal cancer. Currently, a lot of management schemes will say you have Barrett's, let's do surveillance in 1 to 3 years. For low grade or for no dysplasia, low grade dysplasia, 6 months to 12 months. And if you have high grade dysplasia, let's do a surveillance endoscopy in 3 months. Sometimes you'll get some kind of treatment for that. But this isn't perfect. And actually in our center, we are much more aggressive. These are kind of the standard national guidelines for Barrett's, but they're not doing their job. So we have a much more aggressive approach at Hoag, and we're working with societies to kind of make sure that we're changing the way we're managing this on a whole as a medical society. So the risk of watch and wait is that often we miss it. So we wait too long, and even though it's a slow progression, it needs to be taken seriously, because once it gets to esophageal cancer, that's a huge surgery, taking out the esophagus and reconstructing the esophagus with stomach, and often that has not a great prognosis, and it's a big surgery for patients. And we have time to intervene if we can intervene on acid reflux and Barrett's esophagus in a more timely fashion. So the estimates for esophageal cancer and now this data is a little bit older, but the trends are still there today. So we have about 16,000, 17,000 new cases a year. And we have 36,000 people living with esophageal cancer in the US. The average age of diagnosis is around 67, and Barrett's esophagus is the primary risk factor. There's been a dramatic rise in the incidence of esophageal cancer in the last 25 years. In this graph, that pink line shows how quickly this is increasing, and it's really become an epidemic. All those other lines, breast cancer has been pretty flat, lung cancer pretty flat, colon cancer. And I think what's happening with the esophageal cancer is that acid reflux is the #1 precursor, and yet as a community, we tend to downplay that acid reflux in general and not treat it as a serious medical condition. So what are the risk factors? We've talked about Gerd, 44 times the risk of Gerd, especially if you've had it for a long time, over 20 years. Barrett's esophagus, 40 times the risk. If you have Barrett's esophagus, we need to start intervening or think about intervening. And then there's other things like alcohol and tobacco, but those are actually less of a risk than acid reflux. So chronic injury, untreated, leads to Barrett's esophagus that goes through the phases that eventually leads to esophageal cancer unless we can intervene and stop that progression in its tracks. So how do we do that? Well, we've actually got a really great model for us. So colon cancer also has a precancerous lesion. It's the polyp. And so in colon cancer, they've actually done a really great job of kind of stopping that increase of the incidence of colon cancer and decreasing the annual deaths from colon cancer. And one of the reasons is that in that field, we've recognized that there's a precancerous lesion, the polyp. We do screening. So everyone at the age of 50, you got to get your colonoscopy because we screen for these lesions. If you have a polyp, they take it out, and then they base your surveillance protocol based on whether you had these high-risk polyps or not. And the management for that is a polypectomy that takes care of it a lot of the times, and you're protected from that progression. Well, we're lagging behind in esophageal cancer. Our precancerous lesion is Barrett's. It has about the same risk of turning into cancer, and maybe even a little bit more per year. but we don't have screening protocols. And even patients that have symptoms of acid reflux aren't always getting screened appropriately. We have poor surveillance, and our management often is kind of this watch and wait, put you on an antacid, not really do anything except for another screening test at some point. And it's just not ideal. It's not working. So what do we need to do differently? Well, we can't. The good news is that if we find it early, and if we're working with a provider and see some of these changes, we can stop it in its tracks. Barrett's, there's multiple ways. We can kind of burn that lesion off, just like a polypectomy takes the polyp off. We can kind of burn the Barrett's away, and then that can regenerate normal tissue. That's called an ablation. This is what it looks like. It's radio frequency. It burns that layer of the esophagus where the Barrett's is and allows the esophageal lining to reform, and it will reform with normal tissue. 80% to 90% elimination of Barrett's after an ablation. Sometimes you need multiple, 2 or 3. So you can see in this picture, there's the untreated Barrett's and the esophageal cancer, but if we can stop it in its tracks, we can find it early, we can prevent the cancer from happening. So what are our treatment options? This is where, this is what we need to know. Okay, we've got acid reflux. What are we going to do about it to stop that progression? Well, a lot of times we hear about lifestyle changes and, all kinds of things. Stop eating before after 5 and avoid all kinds of foods and sleep with your head propped up at night. And these things can work for some patients. Some patients with really mild, not a lot of anatomical defects of their valve, they may get away with minimizing their acid reflux and even their risk with lifestyle modifications, but this is not going to help the masses. And it's really hard to stick to this diet of no spicy foods, no caffeine, no fatty foods. It's very restrictive. And there's so many triggers of acid reflux that it's difficult to really live with those restrictions. You can prop your head up, and a lot of people have done this. It helps kind of keep everything down, but using gravity, but it's not going to stop the reflux. We haven't prevented the reflux from happening. We're just kind of minimizing how often. There are medications. We all know these. Anyone with acid reflux is taking Tums and been on some or all of these medications in the past. And there's several different kinds. There's Tums and Rolaids. Those can be taken right as you have symptoms. There's H2 blockers. Zantac is off the market, but Pepcid. And then the proton pump inhibitors like Prilosec or Nexium, they all work in slightly different ways, and then you can escalate through these medications. They work by reducing acid and the amount of acid in the stomach, and they do relieve symptoms temporarily. Usually, patients require escalating doses of these medications, so one stops working and then they have to take another, add a nighttime dose to their regimen, and that can be frustrating as you continue to battle this anatomic disease with medications alone. And so the good news is, even though this is what most of us are used to as far as acid reflux treatment, patients tend not to be satisfied with that. Like I said, it can be frustrating. You continue to have breakthrough symptoms. They have to change their lifestyle despite the medications. So there's a big proportion of patients who are not satisfied with the treatment for acid reflux with medications alone. This kind of shows how many people in population have breakthrough symptoms. A lot of patients have breakthrough if they're having chronic reflux or daily reflux symptoms. The other question that's come up a lot lately are PPIs as safe as we thought they were? We used to think they were as safe as drinking water, had no side effects at all. But we're learning that that's not quite true. They can lead to pneumonia in some patients, cardiovascular risk factors, vitamin D deficiency has been reported, cardiac issues have been reported, kidney disease, dementia. There's a lot of literature out there just kind of informing us that maybe they're not as safe as we think they are. individual risk for each patient taking this is probably very, very low. So even if you've taken them for a long time, that may not always be the worst thing for you. But they're not as safe as we once thought they were. So one of the biggest myths is that acid reflux medication stops at reflux disease, but it doesn't. It decreases the symptoms. So it decreases the acidity so you don't feel the reflux anymore. You're still going to have reflux if you're prone to that and have gastroesophageal reflux disease. So studies basically have shown that patients reflux the same amount on and off medication. It's just how acidic that reflux is. And we know that it's not always the acid that's causing the injury, especially with Barrett's. We think it's the bile, and bile is not acidic. So it's not going to stop the progression. Antacids alone are not going to stop that progression to esophageal cancer. So they work by reducing acid, and that, like I already mentioned, they don't have any effect on the bile, pancreatic enzymes, pepsin, all things that can injure the lower esophageal lining as well. And patients reflux the same amount. It's just the amount of acid that's refluxing. What they don't do is really restore the crux of the problem. We're not fixing the valve. And acid reflux is an anatomical problem where the valve isn't closing behind the food bolus, it's not closing appropriately. So if we can intervene on that valve, we can stop all the reflux from occurring. So the thing that antacids do help with is they help with esophagitis. They help prevent strictures. Some of these complications of acid reflux, they do help with. They help with decreasing that loss of muscular strength of the esophagus, that squeezing and protecting that. They can decrease pulmonary problems because pulmonary and ENT tend to be an acid problems, but Barrett's esophagus, we're not quite sure that it's going to help the progression of Barrett's because that seems to be more related to bile. And it hasn't really changed our cancer risk because we've seen the incidence of esophageal cancer go up despite more of the population getting treated with antacid medications. So this graph shows that the progression of cancer with patients taking no PPI, frequent PPI, or daily use PPI. The interesting thing is that more patients taking twice or daily antacids ended up getting esophageal cancer, probably because they had worse disease to begin with, not necessarily that the medications are causing cancer, or that patients think that they're protected, so they don't do as many surveillance studies because they're not feeling the symptoms as well and so as much, and so they think that they're protected. So that's probably why we're seeing that in that study. So antacids are not protecting patients from getting cancer. So we have to think about other treatment modalities. This is another paper that kind of looks at Barrett's esophagus, and we also see that in this study, it doesn't change the progression of Barrett's. So what's the goal of anti-reflux surgery? And that's to prevent all reflux, to prevent the problem, to restore the valve to as normal as possible so you don't have acid or any other gastric cancer refluxing into the esophagus. So this is usually done minimally invasively, small incisions. Usually patients can go home either the same day or the next day. And traditionally, it was the laparoscopic Nissen fundoplication was the gold standard for this. That was the most popular thing. If you're going to wrap the stomach, it was the Nissen. We also have partial wraps called the Ppis or the Watson. We have endoscopic treatments, the transoral incisionless fundoplication, which is an option where you can recreate a valve endoscopically. However, that's not changing the diaphragm, and we know kind of the diaphragm and the LES have something to do with the barrier, but so some patients are a candidate for that. And then we have magnetic sphincter augmentation, which is a Lynx device or a ring of magnets. So Nissen fundoplication does a really good job of stopping acid reflux. So you would wonder why more patients aren't getting this treatment if it stops acid reflux and it can kind of prevent that transition to cancer. The problem is, although it's done laparoscopically with minimal pain and small incisions, it's about a 1 to 2 hour procedure. It's an overnight stay with 1 to 2 weeks off, although 1 week off work usually. Some patients go home the same day. It sounds like a really great option. 90% effective of restoring the barrier to reflux. It also stops bile. You can usually get off all heartburn medications, and it decreases the chance of Barrett's and esophageal cancer. So this is a really great operation to treat the problem and not just the symptoms. The reason, some of the downsides to the Nissen, however, are that it's technically a complicated surgery, and so success of this procedure for patients changes whether you're doing it at a high volume center or in a lower volume center. So surgeons that do a lot of these have better success rates than surgeons that don't do as many. So they've got variability. Also side effects. So you sometimes when you are not used to having a valve and then we create this really great valve that's really strong, patients have difficulty belching or vomiting. It doesn't kind of release air in that direction because it's really preventing gastric contents from coming up, and that's what belching and vomiting is. That can create some gassing and bloating because you're not burping as much. You can have some difficulty swallowing, but that tends to be short term, meaning it kind of feels stuck because you're not used to having a good valve there. So now you're feeling that food kind of sit around more than you usually would. So there were some problems, and I think the gas bloat was one of the biggest things that kept patients and GI doctors from referring patients to get this procedure. It's a slow advancement of diet as well, 4 to 6 weeks until you're having a normal diet again. So there are endoscopic methods, which can work for a certain subset of patients, which can, as I said, the transoral incisionless fundoplication. Some of the others didn't work as well. There's pictures of some other endoscopic things that didn't work as well because they didn't address the diaphragm barrier. The nice thing about the transoral or the TIF is that you can do endoscopic and work with a surgeon at the same time to help with the diaphragm portion of the valve too and get better results. So what's the future? What else can we do? We had some problems with laparoscopic fundoplication. There are varying success. I think, this has to be taken with a grain of salt. Some patients are going to want the Nissen because they have a really bad reflux, and that's what we're going to need for that patient. Some patients have mild reflux, and we're going to kind of say, you know what, we need a little something else, like a little lighter valve for you. But a really good option that's come along is, I'm going to skip this because I've talked about it already, is the Lynx. So the Lynx is a magnetic ring that's used to augment the sphincter of the esophagus. It's rare earth magnets. It's encased in titanium. It stretches, or when the food bullets comes in, and then it snaps back shut as soon as the food goes through there to prevent acid reflux. It's MRI compatible, so you can have MRIs up to a 1.5 Tesla, and it is very good at restoring the valve. So oops, I go back there. So how does it work? I thought it was going to start on its own, but it's okay. If it doesn't, we're going to try one more time. There we go. So we're going to see the same anatomy again, the esophagus coming down to that lower esophageal sphincter. Now we're going to have already fixed any hiatal hernia. If there is a little bit of stomach or if that diaphragm was loose, we'll have fixed that already. And then we place this around the lower esophageal sphincter. The really nice thing is that, like I said, as that food comes through, it snaps back shut, stops reflux from coming up into the esophagus. So it's a really nice option. It doesn't kind of use your stomach. The Nissen fundoplication takes part of your stomach and wraps it around the esophagus to create the valve. And this is a little bit more reproducible. So it doesn't, it's easier to place, and doesn't change as much with the surgeon. It's more reproducible. So this is what it looks like when it's on the esophagus. creates barrier pressure of 20 millimeters of mercury. The good thing about that is that if you have to burp or vomit, the pressures can overcome that, and you can burp and vomit more easily with this than you can with the Nissen. It was FDA approved in March of 2012, so a long time. It's safe and effective. This is kind of, oh, I did it again. 1 second. I have to go back. See if we can get this video. Is it going to play? All right. All right, so this is a minimally invasive or laparoscopic surgery. We're kind of finding that area of the esophagus called the lower esophageal sphincter. And we're going to dissect out kind of that lower esophagus. Once we find it, we're going to place a sizer. This sizer basically tells us how big. It's like a bracelet. We want to know how many beads you need in order to fit around your esophagus. So this is going to tell us how many beads in the bracelet you need in the links. Then we're going to kind of place this around the esophagus. That's rubber thing is something that we'll take out at the end just to help us with retraction. And then we clasp it into place just like we would putting a bracelet around a wrist. And what that's going to sit, you can notice it's pretty loose. It's not compressing the esophagus. It's pretty loose, but it's going to snap back shut and really augment that valve and prevent reflux. So pre-links, it looked like this. So we talked about how that valve was weak, and what we're looking at here is an endoscopy picture of the valve, and you can see that there's kind of space around the scope, and afterwards we've got a nice valve that's tight around the scope, so you can even see the difference endoscopically from the inside. This is a minimally invasive procedure. It takes about 45 minutes. It takes a little less time than the Nissen fundoplication. Most patients can go home the same day, resume a normal diet, so you don't have to be on liquids and then soft and then a regular diet, so they're on normal diet sooner after surgery. And the nice thing is, because it allows patients to belch and vomit, they have less issues with gas and gas and bloating, which can be uncomfortable for patients. So then you're not trading one set of symptoms, acid reflux, for another, gas, bloat, and discomfort. And the nice thing is it's also removable. So if this wasn't working for you for some reason, there's about a 4% of patients where their esophagus, it's kind of too strong of a valve and the esophagus doesn't push through it the way that it should. So about 4% of the time we do remove it because the esophagus isn't pushing the food down the way it should. It does protect acid reflux really nicely. What does that look like? And this is compared to the Nissen, because the Nissen was great at protecting reflux. It just had some side effects. So we wanted to try and diminish the side effects. This is pre and post links. This is acid exposure times in multiple different studies, and you can see every time it's normalized acid exposure. This is a symptom score that patients fill out to let us know their symptoms and how their quality of life is. So in the orange you have pre-op, and then post is a decrease in that score, so they're doing a lot better across the board in multiple different studies. And then are the patients off the antacid medications? And again, we see most patients, 90% of patients are off all antacid medications after this procedure with minimal side effects. So this is, lot less side effects from this procedure as some of the others that we had in our toolbox in the past. It was published in this journal as a new up-and-coming, very exciting treatment for acid reflux, and it's sustained over 5 years. So that excitement, that initial excitement, it worked really well right after surgery. Well, is that durable? Does it last 3-5 years down the line? And it does. We have 5 years data that shows that that reduction in symptoms, that quality of life score are maintained at least to 5 years, and we think even longer. We just haven't followed patients that long. Freedom from PPI. In that green, most patients are off antacids at 5 years even, and this is the quality of life scores, off PPIs. It looks really nice. Now this is where we're compared to the Nissen fundoplication. The whole thing is the Nissen did a great job at acid reflux control, so we want the links to be just as good, or else it's really not the better option. And you can see that it is. It's just as good at preventing acid reflux. It's just as good at getting patients off their medications. And the side effect profile is less. So this is what we really wanted to see, is that the side effects wasn't as bad. So you are able to belch and vomit afterwards, moderate dysphagia, or feeling like food gets stuck, but that's because you have a new valve. And we've diminished gas bloat. So we've helped with the side effects. And really, that I talk about the links a lot because we don't want to trade one set of side effects for the other. There are other options that have a similar profile to the links, but this is new technology, and I want you to be all aware of that as well. So the better way to treat GERD: early diagnosis. A lot of patients are treating this on the own and not even having a provider engaged with them as we treat acid reflux. So the number one thing I want to say is work with a provider, get a screening endoscopy, take a look, make sure you're not having silent complications. And then it can be a progressive disease, so we want to try and augment that sphincter. We want to help that valve close appropriately, and then that's for progressive disease. If you have a really advanced disease, we may have to do the Nissen fundoplication, which has shown to, be our gold standard, but we reserve that really for patients that are really at high risk of esophageal cancer at this point. So in summary, it is a serious condition. There's a lot we can do to intercede, and we're not doing a good enough job at interceding in acid reflux and the progression to cancer, basically because the myths surrounding acid reflux and its severity, what it can lead to. So not everyone with acid reflux is going to have these complications, but we want to be able to see which ones are, and that's why it's important to have a medical provider help with your treatment, and that medications aren't going to treat all of this issues. It's not just about symptoms, it's also about preventing complications and progression of a disease, and really fixing the valve and fixing that anatomical barrier is going to help do that. We want to decrease that progression. So we need to not rely so much on antacid medications, but really intervene early, prevent that progression to esophageal cancer. We've kind of talked about this already. The valve is the problem. In order to really fix acid reflux, we need to fix the valve. Thank you. I'd like to take questions at this time. I know I've talked about a lot. I hope I didn't scare too many people, and that's not the purpose of this talk, but it is to let you know the severity of kind of what we see as surgeons. I have questions that are being handed to me. I'm going to try and get to as many as we can. Do we know what time it is right now? 6:13. Okay, we have like 15 minutes for questions, so this is good. Okay, let's see. Okay, so can someone with acid reflux and hiatal hernia practice intermittent fasting? Yes, they can. I think, I don't think that there's a problem with that. That's like a very popular diet. For those that don't know, you basically eat just with a certain time frame from like 11 to 5 or so. The good thing about that is you stop eating hours before bedtime, so that can help with acid reflux. It's not dangerous. It's not going to prevent all of acid reflux necessarily, but it can help with some of the nighttime symptoms, I think. What role does stress play in contributing to the LES weakness, if any? I don't know that we know exactly all the mind-body connections. We do know that stress decreases kind of the mucosal barrier to the lining of both the esophagus and the stomach, and can lead to ulcers. Gastric ulcers are actually a little more common than acid reflux, but acid reflux can increase too in high stress. We don't know exactly, honestly. but we see a correlation. We just haven't really been able to understand why that happens. But we think it has something to do with a decrease in the mucosal, natural mucosal barrier. So if you have a decreased barrier, then more likely to have injury. Okay, so yeah, so this is about a low, the FOD diet or FODMAP diet. There's a lot of different acid reflux diets out there. Do they work? There's triggers. There's multiple triggers for acid reflux. So yeah, some of them are going to prevent the symptoms of acid reflux. But like I said, even if you have less symptoms, that's not necessarily meaning you have less reflux or gastric contents coming up into the esophagus. You're just maybe not feeling them as much. And it can probably help with decreasing your risk of esophagitis and strictures, because those are more related to acid. So if some of these diets decrease the amount of acid production, so it can help in that and make the reflux contents less acidic. So it can help in some cases, but it may not be the only thing that you need. And like I said, so in that case, I think having a provider at least do a surveillance, at least if you have chronic acid reflux, someone to take a look inside and look at the lining of the esophagus to know if you have injury and how high your risk is for progression. You may have no injury and you may have fairly normal anatomy. And then some of these other interventions are going to work better for you than if you had a really large hiatal hernia and anatomical defects, then it may not work as well. How is coughing linked to heartburn? Coughing, acid reflux can come all the way up the esophagus, and if it comes all the way up into your throat and kind of gets into the trachea, that can cause coughing. Could coughing and constant clearing of my throat be a symptom? It can. So these are kind of what we call atypical symptoms of acid reflux. So not everyone that has those symptoms has acid reflux, but if you have kind of ruled out other more common things, and we can prove through the workup that you have pretty significant acid reflux, then we can make the correlation between acid reflux and those symptoms, and then maybe treatment would help you. Okay, in the pictures that I showed of Barrett's, the lining of Barrett's esophagus is very red. Is that blood or bleeding? It's not. Actually, gastric lining is more red or pink than esophageal lining, and it's just the nature of the cells that make up that lining. So they look different on endoscopy. So then they're kind of more pink. I think the pictures, maybe the lighting showed more red. But yeah, so that's actually what gastric lining looks like, or stomach lining, and it's just creeping up the esophagus as the esophagus tries to protect itself. Does having another form of cancer make your chances of esophageal cancer higher? There are not necessarily. No, there are some genetic predisposition to cancers in general. So there is like a mutation in very select cases where if you get one cancer, you can have multiple cancers, but that's a genetic syndrome that's rare. So just because you have one type of cancer doesn't mean your chance of esophageal cancer are higher. Okay, yeah. Do you have bile in your stomach if the gallbladder is removed? You can. So the gallbladder is a place to store bile and then secrete bile into the intestine, but it's not where bile is made. So bile is made in the liver, and the liver secretes, if you have a gallbladder, it can secrete directly into the intestine, or it can go off into this little reservoir, the gallbladder, to secrete when you have food, and get a big bolus of bile all at once when you eat. But if you take that reservoir away and you take the gallbladder away, now you haven't taken away the direct path from the liver to the intestine, so you still have bile secretion. It's just you're not getting that increase when you eat as much. And so yes, you can still have bile in the stomach even if your gallbladder is removed. Does the Lynx magnets have a shelf life and need to be replaced after a number of years? So no, it doesn't. The rare earth magnets have been tested and for as an equivalent of 100 years, and they don't wear out. The magnetic forces don't wear out. Now, we said that you could get an MRI, and you can. 1.5 Tesla MRI is the normal MRI that you get. There are some specialized MRIs that are 3 Tesla. That just means it's a stronger magnet, and that can actually demagnetize the Lynx so that it doesn't work as well. Does Crohn's disease contribute to acid reflux or esophageal cancer? We don't think so. We don't think that there's a strong correlation between the two at this point. Oh, someone asked about the Lynx procedure with a 3 Tesla MRI. So like I said, it won't fly out of your body, cause injury or anything like that. But it could demagnetize the Lynx and make it not as functional. So you could have recurrent symptoms if you do get a 3 Tesla MRI, and we have seen that before. So then, you don't have as great acid reflux control, and you'd have to decide whether you're going to replace that, take it out, do something else like a tissue valve, something like that. Now I have a question that I don't know if I can answer. I can read it out. What is exactly is an inhaled smoke that causes the sphincter to relax and create reflux? I don't know. I'm not sure. There's a lot of different chemicals in smoke that can relax muscles and smooth muscle. I'm not exactly sure what component it is. I have more questions. Okay. Can a Tiff procedure be done more than once? It can, yes. It's kind of harder to do that more than once, but you can revise it. So a Tiff is the transoral incisionless fundoplication. It's an endoscopic version of LES augmentation, or the wrap that I showed. It takes the stomach and attacks it to the esophagus and creates a wrap from the inside. That procedure can be revised and has been revised, but it's kind of just tailoring it a little bit. So you can. It depends on the patient and what exactly is wrong with that, and to see if you could redo it. Can PPIs cause joint pain or SI joint pain? I don't think that I've seen a link like that. So I would say in most cases, no, I haven't seen that link described. Oh, okay. So what size Heidel hernia would merit a Tiff or a Lynx? So anytime you have a Heidel hernia, you need that fixed surgically, and there's no way to endoscopically fix a Heidel hernia or reduce the stomach back into the abdomen at this point. So if you have a Heidel hernia, you can still get a transoral incisionless fundoplication. We call that a C-Tiff, or combined surgery with Tiff. So, but you have to surgically repair the hernia and then pick the valve or the augmentation that you want for the valve itself, which can be Lynx, or then you could go in endoscopically, or we could do it like a wrap, like a Nissen or a partial fundoplication. So if you have a Heidel hernia, you likely will need a surgical portion of that. It has to be a surgical intervention to fix it. Okay, so this patient, if they had a Tiff in the past that didn't work, can they now get a Lynx? Yes, we'd have to make sure that motility is good, the esophageal motility, and because we're converting partial to a full fundoplication or a stronger valve. So we'd have to make sure that you had good motility in order to do that. But yes, you can revise that surgically. And often the Tiff fails because you get a Heidel hernia. Most of the time when a Tiff or a Lynx or a Nissen fail, it's actually because a patient develops a Heidel hernia, not necessarily that the wrap failed. So we'd have to look into that and kind of see why it failed. So the cons of Tiff, what are the cons of Tiff? Like I said, that's endoscopic. It doesn't address the barrier, the diaphragm. So if someone has very minimal anatomic defect. Their anatomy actually looks pretty good on endoscopy and all studies, and they still have breakthrough acid reflux that's pretty severe, then a straight transoral incisionless fundoplication can be a good option for those patients, because then you're just addressing reinforcing the valve, but you're not needing to do a lot to the diaphragm because it's not that abnormal. But anyone, and most patients that have acid reflux have some sort of dysfunction of the diaphragm as well. Usually that's noted by a hiatal hernia, even if it's small. So if you have any hiatal hernia or evidence that the diaphragm is at all abnormal, and some say that the diaphragm is abnormal in most patients with acid reflux, then you need to fix the hernia as well. You can still, like I said, fix the hernia surgically and do the transoral incisionless fundoplication. And there's reasons why you may want to do that. Basically, it has, it's a partial wrap, so it's not as strong as a Lynx or a Nissen. So there are times when you want to pick a partial wrap like a Tiff or a Ppis fundoplication. Okay, yeah, this is really an interesting question. So if I have a hiatal hernia, can I just fix the hernia, not do anything to fix the valve? Like, don't do a Lynx, don't do a Nissen, do nothing, and just see how I improve. There have been a lot of studies that have looked at that, because that's been a question that, in the medical field for a long time. The problem is that you don't get great reflux control. About 70% decrease of symptoms, but you still are those patients often are on antacids and medications. They have breakthrough symptoms, and you're just not treating the acid reflux as well as you could as if you augment the valve. I would say that anyone that has a hiatal hernia repair should have some kind of augmentation of the valve. It doesn't have to be the Lynx. We could do something that's a little, a little less aggressive, and wrap a little less so that you can decrease side effects and things of that nature. And that's where coming to a digestive disease center and really tailoring these questions can help. We really, at Hoag, offer all of these things because we think it's really important to tailor our treatment to the patient's specific needs and wants and their concern about side effects or not, and really be able to talk to patients about all the options. So we don't just do Nissens here. We don't just do Lynx. We offer Lynx and Ppis and there's Watson and transoral incisionless fundoplication. There's options. And we do that so that we can really personalize the surgical intervention to what the patient really needs. Is it advantageous to sleep on one side or the other? Actually, they say sleeping on your left side is better for acid reflux than sleeping on your right. Interesting fact. Okay, I have time for like 2 more questions. So, would losing weight help with GERD? It can, because intra-abdominal pressure leads to herniation of the stomach more often. So if you can decrease the pressure, if you think about pressure on the abdomen, pushing up, putting pressure on everything, that's going to drive secretions upward. So if you can relieve pressure, even if you have some dysfunction of the valve, it's going to decrease the amount of reflux that goes up there. I have been diagnosed with Barrett's and then was told I don't have it. Is Barrett's permanent? It can regress. So Barrett's is both endoscopic and biopsies. You have to have it on both to be considered Barrett's. And so it depends on if you have a small segment Barrett's or long segment, and the treatment modalities and how aggressive we are changes. So usually if we have a diagnosis of Barrett's and then it comes back negative at least 2 times in a row, we can kind of say, okay, you probably are okay at this point. We can decrease the surveillance at that point. But we usually don't say that you're free of Barrett's unless we have 2 years in a row of no Barrett's. I think we're out of time, but thank you everyone for joining us and the excellent questions. I hope you've gained a lot of insight. Talk to your provider, your primary care provider, or your gastroenterologist. If you're not seeing anyone for it, at least bring it up and see if you need a screening endoscopy to look for some of these complications and just see where you are on the spectrum. There is a wide spectrum of symptoms and complications. So not everyone with acid reflux is going to get Barrett's and cancer, but we want to find the patients that are have severe disease. The only way we can intervene early is if we know about it and can see it early. So thank you for joining us, and we look forward to treating you.